So that's all. Good morning, everyone. This is Dr. Munjal Pandya from Medical MCQ for all. Those who are new, little brief introduction for just couple of minutes, then we'll directly jump to our more main business. Right. So we are a company based at Ahmedabad and in UAE. Possibly we are expanding to Kerala and Mumbai as well shortly. So this is what we are providing all the coachings and all these things for almost all Middle East country, mainly for the physician, general physician. This is our core area of interest. What we provide basically, it's like almost everything in the basket, which includes mainly the PROMETRIC 1000 MCQ book. I'll show you that book. This is recently updated in January 24. So almost compilation of 1000 plus MCQs are there in this book and right, and it is all subject wise answers with explanation, so it's very handy, easy to carry and lightweighted. Ebook is also there. Ebook is the same version of the hard copy book, so if someone is interested in hard copy, ebook, both are available. Online coaching, absolutely, this is our unique product, what we are doing it for last few years, and people are enjoying. Absolutely, we'll get some feedback from the newcomers, those who joined today first time. We have WhatsApp subscription, we have Oman Viva and Oman Viva coaching too. We are providing data flow services now. Dr. Anjali is there in Dubai, so Dr. Anjali is taking care of this complete data flow from Dubai only. So if anybody needs help, just do let me know. You can approach us anytime. You can directly approach Anjali. I'll share her number in group. We provide again a short package where it's like guaranteed package, and this mobile application. I would like to reinforce those who are using the website but not downloaded our mobile application. I request you to download the mobile application. Excellent applications, and completely you can surf whole the website on your mobile with Android as well as on iPhone. So these are the few key things with us. This is Dr. Munjal myself. I did a fellowship in hematology post MBBS in oncology, and I did my bone marrow transplant training from Italy, Rome, which is considered to be the one of the best transplant center in the world, practicing for more than 20 years and in academics, and deliver almost thousands plus lectures, and treated more than 100,000 patients so far in clinical practice. So probably my experience will definitely going to help you here today. So this is Dr. Aarti, who is a consultant pediatrician and gold medalist too from the Baroda University. She is a consultant pediatrician taking care of pediatric lecture. She is Dr. Maddie. Many knows because already few people are joining the coaching. So she is again a emergency physician internal medicine based at Oman now in Muscat. So any help needed, just feel free to call us. She is Dr. Sikha. She is a consultant gynecologist based in India, and she is taking all our gynec lecture. He is a gastroenterologist. He is a DM, super specialist, Ankit Patel, who is taking regularly the gastroenterology lectures. And there are a few other teams on the behind curtain, Sagar, Pallavi, and there are a lot of people. So this is our contact details, and this is book what I explained you. This is Prometric 1000 MCQ book, right? As I already mentioned you. So this is recently updated books 1000 MCQ book with answers, explanations, and last but not the least, many times we are getting off. I mean, this request from many doctors. I mean, don't take it otherwise, but in general, they cannot afford some coaching or something. So we are coming up with the this noble idea. Those who cannot afford or those who have little cost issues, we this started this new coaching, 40 hours of coaching, which cost usually is 500 USD, right, up to now. So we completely make it just to make it more affordable to everything, because we don't want someone to miss out our classes because of money. So honestly speaking, it is almost half. Now it was like earlier, day before was 500, now it's absolutely, so anybody can join now. Batch usually will start on 15th March and 1st and 15th date of each month. So now next date is 15th, and after 15th first. So 15th and first would be the batch time. So you can adjust, accommodate yourself as per your wish, right? So that's it, and you can apply the promo code. You don't need to call anybody. You don't need to chase anybody. Coaching, go for the online. Look for the 40 hours of online coaching. 40 hours. The cost is 500 USD. But if you enter this promo code, it comes down to 250. That's it directly. So no need to call or anybody. If you stuck up, you can call us, but otherwise it's a very simple, clear cut. We make it for everyone to just to help the students. I mean, those who are really struggling to get the coaching. So now that problem is solved. Now, before starting, let's me tell you, those who are on unmute mode, please humble request to make it mute. If you want to interact, I would be glad to interact, and I wish everyone should interact with me. This is absolutely a learning platform. Nothing right, nothing wrong. No one is expert. Everybody is learning. So don't hesitate. Don't worry about anything. You just need to concentrate. That's it, and try to participate. Answer if the same questions will come in your exam, how you gonna treat, how you gonna answer this. So don't worried about right or wrong, or I mean what. And another request, you just check your score. Check your score. Today's questions are little complex. I'm not trying to scare you, but little complex, so you get to know where are you standing. I mean, what's your score, how is your preparation, how, I mean, long you have to go. So lots of questions will be answered today by self assessment, so you do your assessment, right? So that's it. So we'll jump on the first questions as usual. You have 60 to 90 seconds, max 1 minute for one questions. So you need to practice from day one in your practice, that you supposed to read complete questions, answers, right, all the options, and then interpret in your brain and mind, and then you have to post answer ABCD, right? So time management is extremely important, so you need to be a little faster, right? Though we are going little slowly here just for the coaching purpose, but in day-to-day practice, you need to make it little faster. Otherwise, out of 150 questions in DHA, you may end up with just, I mean, solving 120, 130, and unfortunately, you probably not desired score. So make a time practice. First questions in front of your screen. A 21-year-old college student is brought to the emergency department after having attended a party at which he was offered a substance blotted on a small sheets of paper. You can see a small sheets of paper. I got a picture. A few minutes after placing the substance on his tongue, the student noticed that the edge of the wall had begun to look like a cylindrical bar with flashing lights alternating in bright colors alongside the bar. At one point, he felt that the wall of the room were shifting horizontally and spinning. This effect lasted for about an hour and then uh, dissipated. Which of the following is the most likely cause of this patient's symptoms? Is he on a cocaine? Is on ecstasy, heroin, LSD? The small form is LSD, that is lysergic acid diethylamide, and marijuana. So this is kind of substance abuse, very common, frequently asked questions in exam. Don't expect every time a lollipop questions in exam. So you need to prepare yourself little harder as well. Post your answer. Yeah, so anyone, any volunteers can tell me. I mean, you posted the LSD, right? So why LSD? Why not this cocaine, right? Why is not marijuana? Why is not heroin? Anyone? This is learning platform. Now, real learning starts with the interaction, because you posted the answer, but you need to know na, whenever you are giving the answer in exam or anywhere, right? What's your main thing is to, you need to know the right inclusion and exclusion criteria, because you should know now what happens in cocaine poisoning, what happens in ecstasy, what happens in heroin. So once you know, right, the inclusion exclusion, you never go wrong for any questions. Anyone? Anyone? Yes. No one. No comment
Sir,
from any.
may I?
Yeah, anyone, madam. Don't ask anyone. This is
Sir,
open
uh,
platform
okay,
discussion.
this the reason I chose the answer is not because of medically. It's just from what I know, like the one in blotting paper, what you get is normally LSD. That is why I don't know the medical reason behind it.
Fair enough. So, do you know, madam, just for understanding, what happens in cocaine poisoning? Possibly, they may ask you the cocaine poisonings, right? So, if they make a scenario of cocaine poisoning, what you expect in the scenario? What happens exactly in cocaine poisoning? What happens in heroin poisoning?
Rolling of bugs in cocaine.
Sorry, what happened?
Crawling of bugs.
Crawling of bugs.
Sensation,
Okay,
like sensation in
okay.
cocaine poisoning. Not sure about
Some
heroin.
paranoia, something will be there in marijuana and cocaine.
Fair enough. Fair enough. So what's your homework? Your homework, right? So just have a little idea. I don't want you to do a PhD on cocaine poisoning, right? Or cocaine toxicity or overdose. Just you need to know the basic. If the cocaine, because it is not, I mean, mandatory that they will ask you the same picture and same questions from my things, right? They probably ask you the cocaine. They probably ask you the heroin. They probably ask you the marijuana. So here the answer is LSD, the correct answer. Now see the beauty of this, the patient presentation is like due to LSD, which typically causes powerful sensory disturbances such as the movement of shape, light and colors. Everything is there in the scenario, right? So all are there in this scenario. So you need to know the basic things, each clue point for everything, right? What happens in cocaine poisoning when there is a cocaine poisoning, right? So what cocaine poisoning is most likely due to patient sensory disturbance. Although it is important to note that the cocaine can cause hallucination, which is not there. Hallucination is not there, right? Either it's a visual hallucination, auditory hallucination, showing something horse running, or listening something from the window. This is all hallucinations, right? And the psychosis, which, right, psychosis when taken in a large amount, cocaine can be snorted, sniffed, injected and smoked, but it is not usually taken oral on a blotted paper. So this is again, right? So usually how the people consume the cocaine in a different way, by snorted or sniffed or injected, right? So they either, right, आपने देखा होगा ना काफी movie में. So this is like that only. I mean, you need to know. So it is not usually on the blotted paper. So this is completely clear cut given in the scenario that it is on the blotted paper. So this is all small clue, but it's very important how they consume, what they consume. So just you need to see the picture, right? See the picture, the tongue, right? So it's a blotted paper. So it is usually a LSD. What happens with this ecstasy? Right, what third is a heroin is unlikely to have caused patient's condition, as it is usually again the snorted, smoke and injected. This drug causes an intense euphoric feeling but generally does not cause sensory disturbance, what? Heroin. And it is highly addictive, right? So this is the things. Last but not the least, marijuana is unlikely to be responsible for this patient's presentation, as it's usually smoked and it's not known as a hallucinogenic drug. Unlike LSD, it can be abused and use can become a psychological dependent on it, blah blah. So this is, I mean, looks like little tricky questions, but if you concentrate on the important part, what is important, what are the keys. So another, like first time who are attending, let me tell you, the you need to know the triad. You need to know the triad. Those who attended knows triad contains three things. You must know the diagnosis, you must know the investigation, you must know the treatment. So in one MCQ, now make a habit from today onward, right? So what is the diagnosis of these things? Diagnosis is that LSD abuse. How you investigate by the history and classical presentation, and how you treat. So if you don't know the treatment of LSD overdose, go and read it. They may ask you these questions, right? This long scenario, LSD overdose, how do you treat? That's it. So in one questions, you need to make a three questions. One questions equivalent to three questions. Now onwards, you make a habit after the class that in one question. So if you are solving 100 MCQ a day, means you are solving 300 MCQ a day. Why? Because you are also concentrating on diagnosis, investigation, and treatment. So don't just blindly answer the questions, but try to think of the other parts of the things as well, because they can ask mainly the three things: either diagnosis in exam, either investigation in exam, or treatment in the exam. So just post it in your book. Write down what's your answer, whether it is right or wrong. So one answered right or wrong. Check the score end of the things, right? I don't. I'll not ask you, but try to assess yourself. If the same, exactly the same question will come in the exam, what will you do? So don't take it lightly. Concentrate on the next question. 70-year-old woman present to the emergency department complaining of dizziness. she is disoriented to the date and her location, and it is difficult to gather an accurate history. Why? Because she is disoriented, na? With the date and location. So it's difficult to get a history. Her pulse is 48 per minute. Blood pressure is 84 over 60. Respiratory rate is 12 per minute. On examination, her extremities are cool and calming. Her capillary refilling time is 5 seconds. What is the most appropriate therapy? So now see, they have jumped on the therapy, right? So jumped on the therapy means before the therapy is what? It's a treatment. So before the therapy, you need to know diagnosis, you need to know the investigation, then you can know the therapy means treatment. So until and unless you have clarity of this in any MCQ, you most likely go wrong. Why? Because you don't know diagnosis, how you treat the patient, right? So here they are asking the therapy. So is it adenosine? Is it amiodarone? It's atropine? Is it isoprotrinol? And it is metoprolol. Your time starts now. Think of 15-20 seconds and post your answer in the chat box. These questions are not that so toxic as well, but you need to concentrate. Yes, Catherine, can you interact with me if you don't mind? Catherine, are you there?
Yes, sir. Yes, sir.
Yeah, are you comfortable?
Yes, sir.
Great, wonderful.
So in this question,
Yes,
there is bradycardia is there. There is hypotension and respiratory rate. Everything is decreased.
okay,
So the first life-saving drug to be given is atropine. It's saying cool and clammy extremity. So this patient is either in shock, either hypovolemic or cardiogenic shock, I'm guessing.
okay. So dizziness is because of what? I mean, symptoms, they have a symptoms of dizziness. So what do you think? Who is responsible for dizziness? I mean, just trying to little more understand the question.
Uh, Sir, it could be dizziness. It could be. There are various factors. I think maybe
No, no.
even.
In this, what do you think when some patient comes to me with dizziness? What I'll think of?
First, I'll check for the vitals, the RBS and all.
Vitals.
Like if it
Yeah.
is low sugar.
Sugar is normal. Here it's a clear cut, obviously reason, Doctor. C. Blood pressure is
Yes, sir.
84
So
by
yes, blood
60.
pressure. Yes, sir.
Right? So blood pressure is low means what? Perfusion is low. So either in heart, lung, and brain, the perfusion is low, blood pressure is low. When there is a hypertension, the symptoms is headache. Believe me, there are lots of people are confused between this headache and dizziness, right? So when you get a
Yes.
hypertension or any patient comes in the hypertension, they usually don't have dizziness, they have a headache, right?
Yes.
Hypertension, headache, and hypotension, low blood pressure, they usually has giddiness.
Dizziness.
What?
Yes.
Or little vertigo kind of things, dizziness, giddiness. These are the different words they use, right? So dizziness, 70 years old woman present to the emergency. So this patient present in emergency. Why? Because they have a symptoms of dizziness and the blood pressure difficult and is disoriented as well. See, the disoriented. So something goes wrong with the brain, right? Disorientation, dizziness, right? That could be because of low blood pressure and pulse rate is see extremely low. So what is a normal blood pulse rate? 60 to 90 is usually the normal pulse rate. If anything less than 60 is a brady and anything more than 90 is a tachycardia. So this is less than 60 means it's a 45 or 48 or 50, right? So it's a bradycardia. So this is a bradycardia and there is a symptoms. So there are two things. One patient has a bradycardia. Say for example, you check my pulse and my pulse is 50, but I'm absolutely normal. Are you going to treat me? Answer is no. This is one question in exam. Asymptomatic bradycardia should be monitored. It should not be treated with anything, atropine, anything, whatever, increasing the pulse rate. You don't need anything. Symptomatic bradycardia, absolutely yes. Symptoms plus bradycardia you need to treat, and treatment of choice is across the globe is atropine, right? So atropine is the drug of choice, right? Respiratory rate is okay. Usually it is between 16 to 20, 22, like that in adult, right? On examination, her extremities are cold and clammy. Why cold and clammy? Because he has a hypotension, right? Capillary refilling is less because of hypotension. So first of all, what you need to do is to increase the rate increase the force of contraction, it will pump the blood properly and then treat whatever, then you can give IV fluid and all blah blah, right? The protocol or ABC or whatever you want to apply, right? So those who did not answer ABC, now can you tell me atropine little bit more, Dr. Catherine, about what is atropine? I mean, what kind of drug it is? They may ask you few other questions. I'm happy with your answer. Absolutely perfect the way you think. Absolutely. So what kind of drug atropine is? Any idea? Probably you
Mm,
forget some pharmacology,
It's
but I will revise you
some
little bit. Yeah. So what exactly?
muscarinic agonist, antagonist, something.
No problem.
Muscarinic
No
agent.
problem. I'm happy at least you are interacting. I'm extremely happy. So atropine is an anticholinergic drug. Have you heard of anticholinergic drug? Have you heard of
Yes, it
anti?
blocks the acetylcholine.
Excellent. So atropine is an anticholinergic drug. They may ask you, they won't ask you the same question what I'm discussing. They may ask you what kind of drug is this? So this is anticholinergic. Anticholinergic. So whatever action of cholinergic, it reverses the cholinergic. Can you tell me the indication of using the atropine? One is a symptomatic bradycardia like this patient. Am I right or wrong?
Yes.
Any symptomatic bradycardia comes to your clinical practice, right? Give atropine. What else? What other indication where you give the atropine in your clinical practice?
You give for poisoning also. I think organophosphate poisoning.
Poisoning, organophosphorus, that is OP, organophosphorus.
Yes.
Wonderful. Excellent. You are brilliant. Right. So organophosphorus poisoning. What else? What another indication? Anyone? What another indication? Even you can give it pre-operatively in a many patient. The biggest
I
and
don't
sorry, pre-op.
ophthalmic patient. Ophthalmic patient.
Yeah, because what the atropine is, cholinergic is what? It increases the respiratory secretions, right? It increases the lots of respiratory secretions, right? So if you have a lot of respiratory secretion post-operatively, there is a chances of block airway disturbance, right? So they are giving this pre-operatively as well, right? So atropine is also. What are the side effects of atropine? Catherine, what are the main side effects of atropine? If you give the atropine, what happens to the patient? What are the general side effects? I mean, atropine.
The
Atropine
the
flush.
everything will be reduced. All the secretions will be reduced.
Absolutely correct. Absolutely correct. All secretions will be reduced. Absolutely.
Lacrimation, salivation, urination.
Absolutely fine. And that is why the catheterization is required because there is a urinary retention, right? So when a patient is on these things, right? Another is a dilatation of the pupil, right? How you monitor the atropine is working or not. So either you check the pulse,
Yes.
look for the tachycardia because cholinergic will, right? This reduce and atropine, anticholinergic will reduce. So there is always balance in the body, na? Go, I mean,
Yes.
high
Yes.
and low, right? So cholinergic will increase pulse rate and reduce the pulse rate. Atropine increase the pulse rate. Here we need to increase pulse rate. That is why we are giving the atropine. So these are the basic side effects and mechanism of actions of atropine. So you must know. You don't need to just know the only answer. So the answer is a mental status and hypoperfusion. Because of hypoperfusion, hypotension in an elderly patient most likely caused by inferior wall MI or sick sinus syndrome. So sick sinus syndrome, sinus is a SA node. Have you know? Do you know SA node? Right. So SA node as this is the heart basically, right? In heart, right? This is the intraventricular septum. This is just for understanding. So this is right atrium. This is left atrium. So right atrium on the upper side there is a SA node, and SA node will end at the lower part of the right atrium just above the intraventricular septum is an AV node, and atrioventricular sino-aortic, or it is also called as a pacemaker. Pacemaker. So this is the generation point of the electrical activity of the heart. If it is stop, heart stop, patient will die, right? So sick sinus, or this is called as a sinus, right? So sinus or SA node. So if anything goes wrong, what happens? The less impulse is going there, heart is pumping less, so heartbeat is less, right? So what happens? Atropine acts exactly at this place, right? And it increases the heart rate. And that is why your heart rate will go from 48 to 68, right? So you can fasten the things, you can block the things. If the tachycardia, you can block. If bradycardia, you can stimulate. Simple. No need to mug up, right? So this is the SN node to AV node to this is a bundle of his. This is the common bundle. Then it's a right bundle branch block going to the right side, left bundle branch going to the left side, and there are fibers called as a Purkinje fiber. That's it. So this is what the electrical system is. SA node, AV node, bundle of his, right bundle branch, left bundle branch, Purkinjes. That's it. So this is how it generate. It's continuously generate throughout the line. This electrical system doesn't stop even a minor 1 second. If it is stopped, we are no more. That's it. So it's keep going. Any disturbance in electrical activity create a problem. If it is slow, create a problem. If it is high, create a problem. Low, bradycardia, high, tachycardia. Ventricular tachycardia, ventricular fibrillation, fatal condition. We'll discuss in some other lecture. Right? So that's it. Now what, I mean, some people had given the answer, right? This beta blocker, LOL is beta blocker. In general, LOL, LOL, what we chat on WhatsApp, LOL. This LOL is a beta blocker. What? Propranolol, metoprolol, right? Atenolol, bisoprolol. So this all LOL is a beta blocker. So this LOL is a beta blocker. So this is absolutely not answer. Why? Because beta blocker reduces the heart rate. We already have a 48. If you give propranolol, then he has a 28 heart rate and he will die. So this LOL is reduced. This is used in tachycardia, not in bradycardia. Amiodarone is an anti-arrhythmic drug. Amiodarone is anti-arrhythmic drug, usually again used in tachycardia, and adenosine, supraventricular tachycardia, not in bradycardia. So you need to know the little basic pathology. See here, the tachycardia, adenosine is a tachycardia, right? So in one question you can answer a lot of things. Adenosine used in a recurrent AV nodal tachycardia, right? Another amiodarone is used in the tachycardia or in the atrial fibrillation flutter, right? Iso this protenolol that is also used, and incorrect metoprolol again exacerbating the problem. Why? Because already the pulse are low and you are reducing further, so exaggerating or exacerbating the problem. Beta blocker reduces the pulse rate. Already this patient has low pulse rate. So if you don't know the answer, what you can do, by my experience, the trick is that you try to exclude one by one. This is not there, this is not there, this is not there, this is not there. So if you just little bit apply your basic, right, of your pharmacology or your clinical investigation sense, right, then you will also get little better, right? But for that you need to know little basics as well. You don't need to mug up. The mug up will not solve the problem. So if you say, for example, if you don't know the problem, I mean answer, what you will do? Oh, this will reduce the heart rate. So this is not the answer. This is also reduce the heart rate. This is used in tachycardia. This is also used in arrhythmia. Again, what is left? Atropine. Give the atropine. That's it. This is one way of excluding the answer, right? But when you are a bit more better and sharp, when you know other drugs as well, right? So not just by making the one thing, you get to know the idea. Great, wonderful. Check your score. Keep a right. So 0 out of 2 questions is not good score. Check your score. 22-year-old girl, college student, sorry, present to the present to the student health center because of 10 days history of headache, malaise, low grade fever. He also complained of non-productive cough for the past 7 days. X-ray of the chest shows peribronchial infiltrates, right? And what is the most appropriate empiric treatment for this patient? Are you going to give the amoxicillin? Are you going to give the azithromycin? Are you going to give ceftriaxone? And are you going to give a penicillin? So again, my triad will come in any questions irrespectively, right? So you need to know first of all what is the diagnosis of this patient, how you investigate this patient, how you treat this patient. They are directly asking about the treatment. So before treatment, don't you think so? You need to know the diagnosis of this patient. Think of diagnosis. Probably the answer will correct. If you don't know the diagnosis, probably you are in trouble in exam. Take your time. Dr. Jamuna Pai, are you okay?
Yes, following, learning.
Sorry, Jara. Probably you get bored little as well by my talk, but
No. It makes so much sense. Thank you.
but it makes a lot of clarity end of the day.
Yes.
Yes, Dr. Shreya. I usually pick up, madam, the wrong people just to have a little more idea. Yes, Dr. Shreya. Are you there, Shreya?
Yes, sir, I'm here.
Yeah. So I'm just trying to
I'm following.
understand. Don't worry about right or
Mhm.
wrong. Most important thing is the discussion. So what do you think? What's the diagnosis? They did not ask, they did not given
Sir,
the diagnosis in the scenario. They had given that, okay, young girl came to you with fever, malaise, blah, 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 X-ray showing this, how you treat. So before treatment, you need to make a diagnosis, na? You got it.
Yes, sir.
Right. So what's your differential rather? Diagnosis, let me fair
Sir,
with
the
you.
probable diagnosis
Yeah,
might be uh, pneumonia,
pneumonia. In pneumonia, there are any
bacterial type.
category, pneumonia, any category we called as a community acquired, hospital acquired, ventilator associated. Any term is there with this? What do you think? What this girl has? Pneumonia has usually we classify in general clinically as a
Yes, sir.
CAP,
Yes, sir.
community acquired pneumonia. One is a hospital
Mhm.
acquired pneumonia. It's a whole day talk on pneumonia only. And ventilator associated pneumonia. These are the three terms commonly we used
Mhm.
in clinical practice. So what do you think? What it is, community acquired or hospital acquired or ventilator associated pneumonia? What do you think?
Sir, because she is not hospitalized in any way, so it is community acquired.
Excellent. So this is your concept, right? So community acquired is
Mhm.
usually acquired from the community. What is the difference between community acquired and hospital acquired? Community acquired, as the name itself suggests, it got from the community. Hospital acquired means what? Today is 10th date. Patient admitted on 10th
Mhm.
March to the hospital, right? He is fine. His chest X-ray is fine. He has no cough fever.
Mhm.
On 14th of the March, after 4 days, he has a chest X-ray. There is an infiltrate. He has a cough. He has a fever. He developed pneumonia. This is hospital acquired
Yes,
pneumonia.
yes,
Because after coming to the hospital, he got something
hospital.
from the hospital environment, right? And some
Right,
patient
right.
is on ventilator. Before ventilator, he has no pneumonia. But after putting on the ventilator, putting the tube directly going into the chest and lung, now he developed the blah blah blah, this infiltrates and fever and breathlessness and hypoxia and all blah blah. Right? It is a ventilator
Right.
associated pneumonia. So neither it is hospital acquired, neither it is a ventilator associated pneumonia. So community acquired pneumonia, right? So what is the commonest organism in community acquired pneumonia, Shreya?
Mm,
Any bugs?
sir,
That should be community acquired pneumonia. So you are getting some pneumonia or some bugs or some bacteria from the community, right?
yes.
Right. So what is the most common?
Streptococcus.
Mm,
Streptococcus pneumonia.
Streptococcus pneumonia.
S
Wonderful.
pneumonia.
So yeah, strep pneumonia. That is what we called as a strep pneumonia, right? So we need to know, na? We need to know the organism, and depends on the organism we're going to treat any patients, right? If it is a
Right.
MRSA, say for example, if I say you MRSA, methicillin resistant Staphylococcus aureus, answer is absolutely changed in this scenario. I had given you the box, then my answer is a vancomycin. If MRSA is there, then my answer is vancomycin.
Mm,
Audience is
right.
agree or not? Yes or no?
Yes,
MRSA,
yes.
Yes, sir.
vancomycin.
Yes, sir.
Then it's a
Yes.
Banco.
clear-cut guideline,
Ceftriaxone.
right? So that is not the first line, doctor. For MRSA is vancomycin. If vancomycin is allergic or not, then second is a linezolid you can use, right? These are the things which they ask you in the exam as well, but I'm just giving you the broader idea. So whatever they ask, you can answer it, right? So depends on, but streptococcus, as told, streptococcus or strep, right? Streptococcus aureus, staphylococcus aureus. So these are the name of the organism. They are gram positive bacilli, all right? That you also need to know little basic of gram positive, gram negative. We'll discuss in micro or infectious sometime. But this is a community
Mm-hmm.
acquired pneumonia. And in community acquired pneumonia, what do you think, doctor? That would could be the best? Why not amoxicillin? Say for example, discussion. Why not amoxicillin? Anyone, anyone.
Because it has to cover the broad spectrum. I mean, it should include the other causes of community acquired pneumonia also, like Haemophilus influenza and the other things. Whereas amoxicillin will help with streptococcus only.
Okay. And azithromycin?
Sir,
Yeah,
this
go
is
ahead.
This is atypical pneumonia, sir. The patient presents with headache, malaise, low-grade fever, non-productive cough, which can be caused by chlamydia, mycoplasma, legionella, sir.
Excellent. Excellent. So
So this
again, yeah, yeah.
macrolide will be the drug of choice.
Excellent. Excellent. So in pneumonia, go and read homework, your homework. What is community acquired? What is hospital acquired? And what is ventilator associated pneumonia? This one homework. You should have a clarity in your mind. I had given you just brief idea, but go and read it. Pneumonia is one of the leading cause of the death across the globe. Top 10 causes. You go and read it. Any literature, right? It's top 10 cause of death. So you should not miss pneumonia. So these three terms you have clarity. Number two, as sir told, what is typical and what is atypical. I'm coming on that point. So we have many a time heard it is typical pneumonia, it is atypical pneumonia. So what do you mean exactly by typical and atypical? You should know. And another things you should know for the exam point of view. Have you heard of chat score? Yes or no? Chat score,
Yes, sir.
right?
Confusion.
Yes.
Uh,
C for
A
confusion.
yes,
Confusion
sir.
means neurological, is not well.
Neurology.
H stands for what?
No, sir. CURB.
Oh, sorry. I missed it. Sorry.
CURB.
Sorry. CURB. Curb 65.
65.
65. Sorry, I missed that. So C for confusion. C means confusion. U
U for
means
uremia. Uric
uremia.
acid. Urine.
R for respiratory rate. B for blood pressure. And C65 is age 65. So curb 65, for those who doesn't know, CURB. This is again a question. So we are discussing 10 question in one question. So C means confusion, right? U means uremia, means kidney is not well, right? Renal failure. Respiratory rate. B means blood pressure, and 65 is the number of age. Each criteria carries one. This is one, this is one, this is one, this is one, this is one. Why we need to know the curve 65 criteria? What's the importance of doing all the exercise for curve 65 criteria? This is important because on curve 65, any patients of pneumonia, whether community acquired, hospital, typical, atypical, when there is a word comes pneumonia, you need to check the score. You need to check the score, right? So say for example, we'll check the score for this patient. 22 years girl, confusion is there in the scenario, confusion is there, no confusion. So score 0. Uremia is there is no uremia. Renal functions not mentioned means normal. Respiratory rate not mentioned means normal. So score 0. Blood pressure means what? If the blood pressure is less than 90, score 1, more than 90, score 0. So more than 90, 0. Age is more than 65, no, it is a 22, so score 0. So 1, 2, 3, 4, 5. So we cumulated all the score. Score is 0. Right. So what is the importance of score 0? So score 0, score 1. You treat the patient on outpatient department, OPD. You don't need to admit the patient. Right. And 2 is like borderline, depends how the patient's condition. Either you treat on OPD or IPD or indoor patient. And score 3 plus 3 or 4 or 5. Ideally, you admit the patient, and 4, 5 is usually admitted directly in the ICU.
It
So
will
you
show
need
the mortality risk.
yeah. So this is one thing, and another thing is it shows the mortality. So if the score 4 and 5, there are 30 to 40% plus mortality to the patient who admitted with the pneumonia. So this is the extremely important things for you, right, to understand what is a curve 65. So you need to know the curve 65. So if I say this patient is low risk or high risk, this girl is a low risk pneumonia or high risk pneumonia?
Low risk.
It's a low risk. Why low risk?
Low
Because the
risk.
score is 0. If the score is 5, then it's a high risk, right? So high risk, you can't treat on the patients on oral medication. Ideally, you need to admit, right? So this here, as you say, so almost we completely covered the pneumonia part. Let me, before jumping to the things, let me give you the clear-cut idea. What is the difference between typical? Lots of doctors, even after years and years of practice, they don't know what is typical and atypical. We must know irrespective of exam. So typical is what? This is the classical typical streptococcus pneumoniae. H influenza are the typical organism that includes in the typical. Atypical is out, means they are not routinely seen in practice. Atypical mycoplasma pneumoniae, right? Chlamydia, pneumonia, legionella, as sir told, TB, viral fungi, and one I will add in my list is COVID-19. It's atypical pneumonia. We had a pandemic, right? Very bad is the atypical pneumonia, right? So typical and atypical, you need to little mug up this name of the organism. They may sometime ask you Mycoplasma pneumonitis isolated from the sputum culture. What could be the type of pneumonia? It's an atypical pneumonia. Clinical presentation, classical or typical, you can say classical as well, classical, non-classical or typical it is. So typically, usually when there is a pneumonia, what happens? There is a standard classical cough. Here the productive cough, and here the important is a dry cough. Here the dry cough. Here usually not the productive cough, is dry cough. Go and back and check our scenario. What is the written here is a right. What is a non-productive? See, clear cut. It is scenario mentioned clear cut here, right? Non-productive means dry cough. There is no production of sputum. It's dry cough. So this all every word is important. Diagnosis you do usually with the gram stain, right? Here it is useless. Gram stain will not help you. So whenever you do the gram stain from the sputum, right, probably gram stain is not conclusive. Why not conclusive? Because atypical will not, I mean, this diagnosed. Why? Because they have no cell wall. So to gram stain is what? This is bacteria, right? So when you put a stain, there should be a cell wall. But when there is a no cell wall, they will not stain and they will not picked up. Radiology, lobar infiltrate. Here the dramatic change is patchy or interstitial, and the treatment is with penicillin is sensitive, so it works penicillin, right? And this is penicillin resistant. So whenever there is atypical, you need like COVID-19. So COVID-19 we never had given penicillin. Why? Because it's a atypical. Atypical won't respond to the penicillin, right? We had not given amoxicillin, blah blah blah. We had given something different which covers the broad spectrum, and this is the azithromycin. So epidemiologically, younger patient with these symptoms and finding most likely atypical pneumonia. Symptoms of atypical is I already mentioned you in this chart. They have a fever, they have non-productive cough, they have a malaise, and blah blah the symptoms. Macrolide, the classification of macrolide is azithromycin. Can anyone tell me another name of macrolide? One is azithromycin. Anyone? Can anyone tell me?
Erythromycin.
Erythromycin, excellent, wonderful. So we heard since childhood. My doctor used to give me the erythromycin when I was in childhood. So erythromycin, so all mycins is a macrolide. Mycin, erythromycin, azithromycin. So why not erythromycin, doctor? Why azithromycin? We can also give erythromycin, but why not? Why we are not giving erythromycin? Why we are giving azithromycin? So azithromycin is favored. Why it is favored? Azithromycin is favored because it's a high activity, low resistance, and decrease the side effect or toxicity profile, and that is why it is preferred over erythromycin. That you must know, right? So even if, say for example, your community or you are in such a place where there is azithromycin is not available, you have erythromycin, so give erythromycin, that's it. But if you have a choice between azithromycin and erythromycin, better use the azithro. Why? High activity, low resistance, less toxicity. Is that clear to everyone? Yes or no? Yes or no?
Yes.
Yes, sir.
Wonderful.
So can I ask a question, please?
100%.
So can we go for penicillin if it is community-acquired pneumonia,
Yes.
where there is no hint that it's a streptococcal infection?
Yeah. But better use the penicillin is again IV drug and all. I mean, you need to know, or you, so best and safest in any community acquired pneumonia, right? And probably your experience is same, though I am a hematologist, but I also treated many this COVID-19 because every doctor is a chest physician in COVID era, right? So we have to treat lots of patients. So we had given maximum to the patients is azithromycin. It's a community, and sometimes what happen? It will not cover the COVID, but sometimes on the viral infection you have some super added infection, right? Azithromycin is not drug for the COVID-19. You understand? But sometimes, right, it has activity, right? That is what it's lots of clinical data suggests. But you may have, right? Why viral fever we are giving antibiotic? I've seen thousands and thousands of GP in my areas. Even simple cough and simple cold, running nose, they give antibiotic, they give augmentin, they give azithromycin, they give ceftriaxone, they will give cephalosporin, they give levoflox. What sort of antibiotic they are giving? It's a viral. It's a viral. Even if you don't give, they will resolve in 2 to 3 days. If it is, but when you're confused because you're not doing any test, na? Are you going to do any culture from your nasal secretion? No. Are you going to do in GP? It's not possible, right? So what they give? They give you the symptomatic treatment. But every time antibiotic is not required. If patient is toxic, if patient has high fever, if patient's counts are high, patient has some bacteremia symptoms, then you try and give the antibiotic. Otherwise, don't use the too much of antibiotic irrationally. You should have the logic. Why am I or why I am using the antibiotic? It's not just that every prescription amox, clave, augmentin, droxil, cefadroxil, cephalosporin, it rather create a drug resistance, believe me. So rather than just making a shortcut in your clinical practice, try to think whether this patient is genuinely needing this antibiotic, and if you are confirmed that this is classical virus and hundreds of patients nearby community have sneezing, cough, cold, just give them the symptomatic. That's it.
Sir, in
This
this case,
So amoxicillin is not as effective treatment for atypical pneumonia. Ceftriaxone is not effective for atypical, and penicillin is not effective because of not as effective. So azithromycin or macrolide is a drug of choice, as we discussed, and this is clear-cut classification. I tried to gather this chart from some internet, but it would be very easy and a very understandable way it's present. Typical usually less than 2 days, atypical more than 3 days. Age, any age typical, and atypical is usually in a older. Fever high grade, atypical not high grade. Cough is productive in typical, it's dry cough. X-ray usually in typical localized, it is atypical. Diffuse, like remember COVID is a atypical. Organism, strep pneumoniae, pneumococcal and mycoplasma, and lot more long list. An atypical macrolide or tetracycline is the older drug with more toxic side effects profile. That is why people are not using nowadays tetracycline, but it is again a drug of choice. The macrolide is a safer, faster, good coverage. Macrolide is a drug of choice, and there is a ceftriaxone, right? Ceftriaxone is, I guess, the third generation cephalosporin, right? And that's it. So this is what how we treat. So go and read. Pneumonia is one of the hot favorite topic. Either this all community acquired, typical, atypical, organism involved, COB 65 criteria and treatment. 110% questions will come, undoubtedly come. 28-year-old G1P0 woman is 37 weeks pregnant. Her maternal prenatal screening was unremarkable. Her pregnancy has been uneventful thus far. She has several questions regarding what to expect for herself and her child during the first few days after delivery. Which of the following vaccine is indicated during post-natal period? Concentrate on your questions. DPT, diphtheria, pertussis, tetanus, H. influenza B, hepatitis, inactivated polio vaccine, measles, mumps, rubella, varicella vaccine. Sorry for little toxic and weird questions today, but it's important. This may come in exam. Yes, Varun. Varun, are you there in the class?
yes, sir.
Yes, Varun. So what's your answer?
Sir, I wrote E. Measles, mumps, rubella.
Okay, no problem. We'll discuss. What do you think? What this female is suffering from? Diagnosis or what's going on with this female?
No, sir, the maternal and prematernal screening was unremarkable. There was no issue. So we can't give that MMR in pregnancy. So I thought after pregnancy, that was the answer.
Okay, so MMR you want to give. Usually MMR at given at what age? Or are you going to give the MMR in pregnant woman?
Oh, I thought, sorry, I thought it's for the baby. I thought.
Yeah, baby, chalo. Let's say baby, it's delivered. Na, after delivery, they are saying so, right? Child during the first days after delivery, right? So at general, so baby is delivered. At what is the time frame for MMR? Do you have any idea?
6 months, 9 months, and then
Okay.
one booster shot at 12 months, if I'm not mistaken.
Fair enough. So do you think that 6 months, 9 months, or 12 months happens to this baby?
No, sir.
So that answer is gone in general, isn't it? What do you think?
Then I think, sir, hepatitis B vaccine.
No. Sorry. I'm just trying to understand. Then why? How old is this baby? How old is this baby? Baby is delivered, na? They say,
Yeah, just
listen.
one day.
Yeah, first few days after delivery, right?
Yeah.
First few days after delivery, it's not in months, na? Few days only, maybe 5 days, 7 days, 10 days, right? So what vaccine can be given in first 5 days, 7 days, 10 days? First of all, think in that way. Until and unless you have clear-cut idea in my mind, so homework for everyone. We are 50 people in this class now, 50. So this will come in exam. What is live vaccine? What is attenuated or killed vaccine? Killed vaccine. You should know which vaccines are live. You should know at least 1 or 2 or 5 names, right? These vaccines are live vaccine. These are the killed vaccine, right? What is active immunization? What is passive immunization? You should know. Third thing. Third thing is the time frame. At what time, what vaccine has to be given? You should know the time frame, right? So you should know the time frame, right? So do you think this is the worth? Yes. Yes, Catherine. What's your answer, Catherine?
Sir, my answer was hepatitis B because from at the time of birth within 5 days we give BCG, hepatitis B, and oral polio. So there's one other option here which is inactivated polio. So that is oral
So,
polio is killed vaccine. I mean live vaccine. So
so,
by
so,
exclusion, I excluded that polio.
wonderful. So DPT is given at what time usually? DPT. Say, for example, one
DPT,
by one, just understanding. I mean, we don't want to mug up. That is why we are discussing. No? If we want to mug up, then no need to have this class. No? We don't need to mug up. Yeah. So, yeah, tell me. Sorry. Huh? So, yes, Catherine. So, at what this age frame, the diphtheria, tetanus, and DPT usually given by your knowledge? So, everyone should know all this time frame. The answer is hepatitis B. Hepatitis B is the answer here, right? Inactivated polio doesn't help. Inactivated, right? Can you? Sorry for muting all because people are not understanding, right? So this is the thing. Hepatitis B is the only childhood vaccine that is to be given upon delivery. This vaccine is given again when the infant is at 2 months old. So basically, in general, you can remember in that one is 0. This is how we remember 1 and 6, right? So 0 is the day 0, right? When you given the first dose is day 0, right? 1 is after the first dose, after 1 month the second dose. So second dose is after 1 month, and from 0 6 month. So this is third dose. Got it? So 0 mean the day of administration, after 1 month is first, and after 6 month of the first, right? So after 1 month of first and after 6 month of first dose. So this is how it has been given, right? 0, 1, and 6 usually, right? So you just need to know little, and probably the vaccination schedule may little change from country to country, depends on the bugs and organism, right? When I was in Australia, they are not giving the BCG vaccine. Believe me, BCG vaccine is not given in Australia. Why? Because there is no tuberculosis. They have too much of screening program. So at the time of birth, they are not giving regularly. While in India, tuberculosis is the biggest burden, right? So everywhere, right? You check your left upper arm. Those born in India, check the left upper arm. There is a mark on the left upper arm, just at the deltoid. There is one mark. If mark is there, means you received the BCG. Got it? So this is how it works, right? So you need to know little time frame, right? So hepatitis B, right? So hepatitis B vaccine is given, right? And there are lots of questions related hepatitis B. Last time we discussed in our discussion, but we probably discuss next time as well, right? So this is what the thing is. Okay, fine. So let's jump to the next question. A 34-year-old multigravida present to a prenatal care in the second trimester. She reports a history of substance abuse, but states that she has been clean for 6 months. With her second pregnancy, she experienced a preterm delivery at 34 weeks of gestation of male neonate who died within the first day of the life. At that delivery, the baby was swollen with a skin lesion. Placenta was very large. She was treated with antibiotic, but she cannot remember what they were. On a routine prenatal panel with this current pregnancy, she is found to have positive VDRL. What is the next step in the management? Are you going to do a FDA ABS? Are you going to give an intramuscular penicillin? You are going to check and screen for this lupus anticoagulant. You start oral penicillin or you do RPA, rapid plasma reagin test. Yes, what will you do for this? Yes. Yes, Dr. Hem Sagar, any comment? Yes, Dr. Hem Sagar.
So these tests will detect antibodies, but we cannot say it's current infection, right, sir? So we can just treat with antibiotic to prevent transmission to baby.
Okay. Fair enough. So your answer is B. You want to treat this patient. Okay. Fine. Right. Yeah, Shreya.
Sir, we should give antibiotics.
Okay. Which
The
antibiotic you want to give?
penicillin.
Oral or IV or intramuscular?
Sir, preferably oral, if she can take.
Preferably oral. Which oral antibiotic? Can you name the oral
Oral,
antibiotic?
sir, D oral penicillin.
Benzothine penicillin, sir.
Okay. Okay. Anyone? Anyone? Just discussion.
Benzothine penicillin, sir.
Benzothine. Benzothine penicillin you want to
They
give.
asked about the next step in
Yeah. So what is
Yes,
the
sir.
next step in
they
management?
have to.
I want to confirm if this is
When
syphilis.
One by
So
one.
I
Yeah.
like,
Who is speaking?
sir,
Sorry, I mean a lot of people.
so this is Dr. Yeri Madana.
Okay. Yes, doctor. Now what you want to do, sir? Madam?
I want to confirm if it is syphilis. So I would like to do FDA ABS. After
Oh,
confirmation, I'll go for intramuscular penicillin.
wonderful. And why you want to confirm? VDRL is positive.
So it's only a screening test.
Excellent. It's a screening test. It's not a confirmatory test. And it could be a false positive too as well, isn't it?
Yes, sir.
Wonderful. So that's the answer. So answer is FTABS. Do you know, doctor, the full form of FTABS? There must be some name of FTABS, no?
Fluorescent phenomenon antibody.
Yeah. And what is ABS?
Antibody absorption.
Wonderful. Pass. Yeah. So the next step after any positive screening test is the confirmatory test before starting the therapy. So this is the logic, right? Most of the people answer is correct. You start the treatment, but before starting the treatment, what they are saying, what is the next step in the management? So they are asking for the next step in the management. So let me go to. Is my screen is visible?
Yes.
Wonderful. Right. So what they are saying, next best step in the management, and next best step in the management is to confirm. This is any screening test. Few example, right? So say for example, somebody has a HIV, they have done the ELISA, right? Or they have done rapid test in your emergency room. So once it is positive, you cannot start directly treatment. You have to do the confirmatory test, that is called as the Western blot. Have you heard of it? Western blot? Yes or no? So Western blot you need to confirm, right? So here the same screening test is positive. Positive is screening test. VDRL, Venereal Disease Research Lab. VDRL is a screening test. When you screen the female, pregnant female, if it is positive, you confirm it with the FDA ABS, and then you start the treatment. So here what's the logic? The next step after any positive screening test is the confirmatory test before starting the treatment. FTA you must know. Fluorescent, it's not very hi-fi. F means fluorescent technique. Treponema is a Treponema pallidum. It's the name of the box organism. And A for antibody. So Treponema pallidum antibody absorption test. Right. This is the name of this little fancy. Right. So this is the thing. The most important is this part, the below part. Sensitivity of the stage. Right, do you, how, right, again before jumping this I would like to tell you the stages, right? So this is again a questions in exam. Syphilis is divided into the three part: primary syphilis, secondary syphilis, tertiary syphilis. The organism is Treponema pallidum. You must know 100%, you must know Treponema pallidum, right? It is a sexually transmitted disease, STDs, right? Sexually transmitted disease. It can transmit to both the partners, again important. So whenever you are using syphilis, treat the both the partners. That is again a question in exam. You treat patient or patient and partner both, treat patient and partner both, because it can go from male to female, female to male. What happens, right? Primary syphilis, there is a word that is called as a canker. It's kind of ulcer. So this is a classical book picture. This is a penis, and on the penis there is a ulcer. Here the ulcer, this is ulcer. So at the side,
Excuse me, sir. Are you showing some picture? I am not able to see the picture.
no, not see, I am drawing, doctor, I'm not showing, I'm drawing.
Yeah, but the drawing is also I can't see the drawing. I can just see the question.
I
The
can't see it
34-year
either.
Yes, sir, it's
Okay,
not visible.
this is visible, the
No.
slide is
No, it's
visible.
not.
We are still in
But
the question
This,
5
question
slide, sir.
number five.
Sir,
this
now we can see you're drawing something.
wonderful. So now you can see the white page,
Yes.
you can
Yes.
see, right?
Yes, now we can.
Now it's visible.
Wonderful, sorry, change that. So this is a primary syphilis, secondary syphilis, tertiary syphilis. So in primary syphilis, it is usually in the 4 weeks. After infection, 4 weeks. This is 4 weeks beyond, more than 4 weeks to 1 year. And this is usually beyond 1 year. So this is, you just basically you should know the little time frame, how it works, right? So this is one thing. This is weeks, right? Primary syphilis, there is a ulcer on the penis. Usually, this is what we see usually in the book picture. So I'm taking the same. So when there is an infection, within first 2 to 3, 4 weeks, they present with the this infection. If you understand this, you never ever mug up this primary, secondary, tertiary. Simple thing, but you need to understand. So there must be some ulcer. This is at the site of inoculation, right? If it is a this vaginal part, it could be a vaginal part or urogenital part, or it's at the penis. Sometimes oral sex, it could be a mouth ulcer. Sometimes anal sex, it could be at the anal site as well, right? So this is a site of inoculation of the bacteria. So here what you do immediately, you either do the dark field or RPR. This is the initial test you do for the confirmation, and once you do the screening test, you can do the FTABS. This is question in exam, right? And they usually present with the fever, they present with the ulcer, they present with oral ulcer, they present with the anal ulcer. Once, if you don't treat this patient, they will go into the secondary syphilis. And here you can see the same ulcer on the genitals, plus you have the lymphadenopathy, plus you have a fever, plus you have a malaise, and it can involve, believe me, any organ of the body. If you don't treat, then another stage between second and third is called as the latent stage, latent, where it's spread. You won't have any symptoms. Patient even doesn't have any. Here also you have sometimes skin rash, abnormal skin rash on the secondary, and tertiary is usually neurosyphilis or cardiac syphilis. So cardiac and neurological, and this is usually beyond years, 1 year, it could be up to 10 years. So first infection happened in 2024, but patient present in 2034 with the cardiac syphilis. After 10 years, even they can present. So it's a tertiary syphilis, right? So that is what the thing is. So we need to know, right, what this syphilis and what these things are, right? So these are the primary, secondary, and tertiary syphilis, and this we have to address properly. So you must know what these are different type of syphilis. One second, I'm stopping the sharing and again resharing because I override the things. I want to make it more clear. Is it visible to you? Yes or no? Is it
Yes,
visible
now.
to you?
Yes, sir.
Right, because I'm not very expert in IT things. I'm learning. So that
Yes.
is, I cannot erase somehow. I don't know. So I make a sense. So is that clear, right, with you? Right. So this syphilis, got it? So this is the three types: primary, secondary, and tertiary syphilis. The initial test, if you can see, is a VDRL and RPR. See the sensitivity, but what is the highest sensitivity by FTABS? Whether it is a primary, whether it is a secondary, or whether it is a tertiary. So if you don't know the answer, what is the best, you go for the FTABS. Simple as a confirmatory test. Why? Because it's the highest sensitivity and specificity. Is that clear? You can see clear cut the numbers. Here you can see the clear cut number. Can you see the numbers? 95 is higher than 85. 100 is higher than 99. 98 higher than 95. So this is usually used as a screening test. This is confirmatory test. Is that clear to everyone? Yes or no? Yes or no?
Yes, sir.
Yes.
Right. So syphilis is a little complex area, but I try to make it little easy for you guys. Right. And we have a little bit more question, one more question on the syphilis later on. So treatment part will be covered in that. The next questions: bleeding abnormally, a bleeding abnormality during a busy ward round. You are asked to visit a patient. The consultant has not had an opportunity to see. So consultant was in round, but he is busy. So you are told by your colleague that go and see the patient. The only details you are given that the patient is female and was admitted a previous day with the bleeding abnormalities. You are given the results of her blood investigation. PT is high, right? PTT is prothrombin time is unaffected. Sorry, not high, unaffected. PTT, partial thromboplastin time is prolonged. Bleeding time is prolonged. Platelets counts are unaffected. What are the likely diagnosis? Factor 5 deficiency, warfarin deficiency, warfarin therapy, Glanzmann's thrombocythemia, Bernard-Shawley syndrome, or von Willebrand disease. Dr. Naina, any comment? Are you in the class?
Sir, yes, sir. I think it is Bernard Solier.
Okay, 1 minute.
Platelet.
We'll discuss. Bernard Shawley by your sense. Okay, so tell me something about Bernard Shawley. Whatever you knows about Bernard Shawley, tell me.
Sure, sir. It is due to platelet dysfunction.
Okay, so Bernard Shawley syndrome is a platelet dysfunction, right?
Yes, sir.
Okay, fine. Go ahead. So this is platelet dysfunction. What else you know about Bernard-Scholier syndrome?
No, sir. But now when I'm thinking, the platelet count will also be less. There will be thrombocytopenia.
Hmm. So would you like to change the answer?
Yes, sir.
Sorry, you change it. I'll give you opportunity which is not there in the exam room. Change the answer. Meanwhile, you think over it. Whatever you ask,
Yes.
I need the explanation. See, otherwise it's like mug up. You understand? We don't need to mug up.
Yes, sir.
Okay, fine. Anyone else? Anyone else wants to try? Open for all.
Sir, it's von Willebrand's disease.
Who is this? Your name, please. Hello. Am I audible?
Yes, sir. I'm Dr. Edil Madana. It's von Willebrand's.
Von Willebrand. So now tell me, what are the points favoring the von Willebrand?
So prolonged PT and prolonged APTT.
Prolonged
Bleeding time
bleeding time. Okay, so bleeding time is prolonged here. Okay.
and prolonged partial thromboplastin time.
Okay. So how you correlate that bleeding time is increased? Prolong means increase, isn't it? And how the PTT is increased? How you correlate in this patient? What happens wrong? What is von Willebrand disease basically? What is excess? What is missing? What is von Willebrand? This is a man or male or female? Who is this von Willebrand? Yes,
Like
doctor.
something to do with the addiction, more, I mean that protein.
Factor
Something
8,
to-
von
Deficiency of
Willebrand factor.
Yeah, so I'm just
deficiency of
trying to understand your concept that okay, you told me von Willebrand. Okay, fine, von Willebrand. You told me Glanzmann's, okay, but you need to convince me why it is von Willebrand. This is how, because in this question we'll discuss 10 questions related with the PTA, PTT, and I'll completely crystal clear your concept in just 5 minutes, right? So once you understood my talk, next 5 minutes, all queries related with ICU, PT, PTT, bleeding time, blah, 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 all clear. But what you need, what you understand by von Willebrand disease, what happens exactly? What is lacking? Problem is where? In von Willebrand factor problem, or in the platelet problem, or in the factor 8 problem? Where is the problem?
Sir, it's a von Willebrand's is a bleeding. I mean, it's a platelet dysfunction. So the bleeding time will get prolongated.
Okay, so it's a platelet dysfunctions. So von Willebrand disease, right? There is nothing to do with the von Willebrand factor. Do you know there is one factor? There is a one factor called as a von Willebrand factor, like clotting factor, right? There is a von Willebrand factor. Do you know that or no?
Yes, sir. There is a deficiency of von Willebrand factor.
Deficiency of von Willebrand factor. So what is the functions of von Willebrand factor in our body? Say if I say your von Willebrand factor is absent in your body, what happens?
It will help the
binds the platelet to the endothelium.
Platelet aggregation.
Okay, so if the von Willebrand factor or von Willebrand antigen is absent in anyone's body, there is a clotting or bleeding?
Bleeding.
Bleeding.
You say confidently. You say confidently. It's a bleeding, no? It's a bleeding disorder. Von Willebrand disease is a bleeding disorder, right? So say for example, there is a primary problem is a von Willebrand factor, or it's kind of protein in the plasma which helps to clot the blood. Am I right or wrong?
Yes, sir.
Right. So now the von Willebrand factor is absent. What happens? Does von Willebrand carry something? Von Willebrand factor carries something? Yes, it carries factor 8. What? It carries factor 8. So when the von Willebrand factor is not there, it will not carry the factor 8, right? To really clot happens. So von Willebrand disease basically, right? It's a platelet functions disorder because basically, right? So what happens? The von Willebrand, if absent, two problems happen in the body. Basic, absolute basic. Von Willebrand factor, when it is absent, it will not allow the platelet to make a clot. Number one. Primary pathology, physiology, Go and read it. I read it last night before presenting to you. So it usually does not allow the platelet to aggregate. There are two problems, right? Platelet functions disorder, you know platelet functions disorder, right? So platelet functions disorder is what? Let me tell you.
Complication.
When
Addition.
for clot, these things you required. Whenever you want to make a clot, blood clot, platelet required. Another is 1 Willebrand factor required. Clotting factors required. Fibrinogen required, and few other things. These are the core four things. In platelet, there are two problems: platelet quantity and platelet quality. Platelet quantity we called as a thrombocytopenia. Example ITP. Example drug-induced low platelet. Example dengue. Example DIC. Example septic shock. Example acute leukemia. Long list I can tell. I am hematologist. So quantity means numbers are less. Quantity normal is 150 to 450 is a normal quantity. It reduces less than 150. Seen all the indications is quantity. There is a problem in the numbers. Quantity, the numbers is reduced. Quality is what? Quality, numbers is normal. This is the biggest difference. If you see the patient's platelet count, it is absolutely normal, but still patient is bleeding. Then why it's bleeding? It's a qualitative problem. There is a problem in the quality of the problem in the patients. This is endothelial wall. This is vessel. This is endothelial wall. And let me tell you, from the endothelial wall, something is released called as a von Willebrand factor. Von Willebrand factor is released from the endothelial cell, right? And this is treatment will come. I am trying to clarify your concept. So there are two problems, right? What happens? Platelet, this is platelet aggregations is a problem. If aggregation is not there, platelet functions disorder, right? And this aggregation can be only happen when there is a von Willebrand factor is there. If when Willebrand factor is not there, aggregation is problem. That is why it is a platelet functions disorder. Number two, right? And adhesion. Aggregation is a one issue and another is adhesion, right? So at the site of injury, adhesion is at problem. So these are the two qualitative problem where the numbers are normal. Platelets are 300,000, too much of platelet, but patient is still bleeding. Why bleeding? Platelet are normal. So you have army, but you have no machine gun. What to do? Nothing, right? You have big army, but there is no machine gun. Nothing, right? You have a lot of resources, but you have nothing, something specific, right? You are very brilliant. Patient has pneumonia, but you have no antibiotic. What do you do? Nothing, right? So you have lots of platelet, but platelet, whatever there is not working well. So it's a platelet functions disorder. So this is a one complete different chapter in my book, Hematology. Platelet thrombocytopenia is a different chapter. Platelet function disorder is a different. We'll discuss later on. I'm trying to give you the concept. What happens? So when there is a clot, so this is a, say for example, clot. So here platelet should be there, which should be aggregated well and which should be aggregated as well as adhesion should be there. When it is possible, when there is a von Willebrand factor is there. So von Willebrand factor is also there. If it is not there, it is called as a von Willebrand disease. If the platelets numbers are less, it is called as a thrombocytopenia. If numbers are normal, but the functions is problem, platelet functions disorder. There are three things I try to clarify. Again, you need a clotting factors, all clotting factors you need. I will draw the cascade very shortly. So if this is not there, clot will not there. Everything is there. Platelet is good, von Willebrand good, factor is good, but fibrinogen is absent. It will not make a fibrin mash to make a clot. So anything. So whenever any patient comes to my emergency, I'll go by one in my emergency. Okay, let me check. Platelet is okay. Okay, fine. Factor is okay. How do you know factor is okay? Check PT, APTT. APTT, PT okay. Factors are okay. One Willebrand, okay, I'm thinking of one Willebrand disease. I look at the first platelet count, and then if everything is okay, I'll ask for do the serum plasma one Willebrand factor. Fibrinogen is okay, everything is okay, right? So everything has a two problem: quantitative, qualitative, quantitative, qualitative, quantitative, qualitative, quantitative, qualitative. Most of the problem in clinical practice is a quantitative, very rarely qualitative. Is that clear? And von Willebrand factor, again, let me go you three category: type 1, type 2, type 3. Go and read it. This is absolutely question in exam, which usually we try to avoid. Von Willebrand three types. We always avoid. Don't avoid. Type 1 and type 3 is a quantitative problem. Quantitative, where their less platelet counts are low, while type 2 is a qualitative problem. It's a bad problem. Qualitative problem. When there is a von Willebrand disease, when there is a quantitative problem, 80% of the patients are type 1. So what happens when von Willebrand factor is less? You need to increase the von Willebrand factor. How will you increase? With the desmopressin. Desmopressin. Have you heard of desmopressin? Yes or no? Yes or no? Desmopressin.
Yes, sir.
So desmopressin causes the release of von Willebrand factor from the vascular endothelium, and it stops the bleeding. So when von Willebrand disease patient comes to me with a gum bleeding, oral bleeding, this bleeding, that bleeding, I'll first give in mild to moderate case desmopressin. And if desmopressin is not effective, then I'll give something directly von Willebrand factor. And von Willebrand factor, biggest source of von Willebrand factor is a cryoprecipitate. Cryoprecipitate. Have you heard of cryoprecipitate? Yes or no?
Yes, sir.
So
Yes, sir.
cryoprecipitate. And second thing is a PCC, prothrombin complex concentrator. So prothrombin complex concentrate. This is the third. So that's all. This is the treatment of von Willebrand disease. Mild, moderate, desmopressin. Then if doesn't work, severe case, what you give? Cryoprecipitate. What else? The best you can offer to the patient? Prothrombin complex concentrate. That's it. No need to mug up. No need to mug up. Is that clear? Yes or no? Yes or no? At least
Very
say
clear,
yes
sir.
or
Yes,
no.
sir. Yes, sir. Yes, sir.
Now you read, probably the job will be easy for you. Right? I though practice this for last 20 years, so it looks little easy for me. But I try my level best to gather my knowledge and try to make it in a simpler way as far as possible. So probably that helps. So platelet problem, you understand two problem, right? Same way the you understand. Sorry. So platelet, you understand the problem. Von Willebrand, understand type 1, type 2, type 3, right? 1 and 3 is a quantitative, second is a qualitative. Treatment, you know, clotting factors. Tremendous chart I'm going to draw you, which is absolutely a boring headache topic for everyone. I draw last time. I draw it once again. If you concentrate it, lifetime guarantee, you will never forget this pathway, which usually you try to avoid. This is called as the intrinsic pathway. Intrinsic pathway. This is thousands of questions comes in exam. This is extrinsic pathway. Outside extrinsic, inside intrinsic. Simple. Remember, factor 7 is in extrinsic pathway. First understand. After 7, there is factor 8. After 8, there is a 9, 11, 12. So where is 10? 7, 8, 9. Sir, you did not write 10. So here is a 10, right? And 10, 2 multiplied by 5 is 10. So these three factors are in common pathway. Factor 2, just to make it simplified by my own way, I remember this pathway lifelong by this way. So probably it helps you. So 2, 5, 10 is a common pathway. This is extrinsic pathway. This is intrinsic pathway. Intrinsic pathway is monitored by APTT. No need to mug up. Extrinsic pathway is monitored by PT. That's it. So far clear? So far clear? Yes or no?
Yes, sir.
Yes.
Yes, sir.
Simple.
Yes, sir.
So no need to mug up. 7, 8, 9, 10, 11, 12. 2, 5 multiplies to factor 2, 5, 10 and calcium. Here is also calcium. If you go and open up the book, what happens? This 12 activate 12A, 12A, 11A, 11A, 9A, 9A, 8A, 8A, activate this and then clotting. Same 7, activate 7A, common pathway. And then what happens? This fibrinogen to fibrin. Sorry, this will activate prothrombin to thrombin. Prothrombin to thrombin. This is factor 2. Prothrombin to thrombin, and thrombin will activate fibrinogen to fibrin clot or fibrin mesh. This is factor 13 for your knowledge. All factor comes 7, 8, 9, 10, 11, 12, 13, 2, 5, 10. Is that clear? Yes or no? Yes or no?
Yes, sir.
Yes.
So what do you think that if anything goes wrong in any factor, if factor 7 problem, no clotting. Factor 8 deficiency, we called as a hemophilia A. Factor 9 deficiency, we called as a hemophilia B. Factor 12, 11, hemophilia C. That's it. This is what the thing is. This is how the name comes. No need to mug up. Factor 8, we mug up. Factor 8, 1 will have this hemophilia 8, 9, 11. That's it. Hemophilia A, B, and C. That's it. Right? So this is how the name comes. Right? So this is the cascade completely. So if anything goes wrong, so if you say that hemophilia A, then what happens? What will you going to monitor? APTT. If factor 7, right? Warfarin, act here, warfarin. You monitor PT, PT and INR. This is what? PT and INR, right? And here 10, and this factor 10. So whatever the factor 10, right? If everything is in the rhythm, every factor is in the rhythm, then final clot will happen. If something goes wrong at any level, 12, 11, 9, 8, 2, 5, 10, 7, prothrombin, thrombin, fibrinogen, fibrin clot, any issues there, you won't have a clot. Simple. You won't have a clot. You will not develop a clot, right? Or clotting will not happen. So what's your job is to find out. How you find out? There are two simple tests you can do: PT, APTT, and finally the fibrinogen. That is what I written here. So here in clotting, what will you do here in clotting? Right? You figure it out that okay, fine. Platelets are normal, no platelet problem, no this problem. So these three things you can monitor whole clotting pathway: PT, APTT, and fibrinogen. That's it. This is platelet count number usually, and this is one Willebrand factor. Your clotting done, your clotting done. That's it. Nothing else in the clotting, right? And let me go to the next. This 10A, right? So how the anticoagulant drugs comes in the picture? Anticoagulant. So if you say warfarin is anticoagulant drug, where does it act? It acts on the factor 7. Heparin, where acts factor 8, heparin, right? It blocks the 8. Clot will not happen. Anticoagulant, oral anticoagulant, IV anticoagulant. This is 10 activity, right? So it is called as a DOAC, drug oral DOAC or NOAC, you can say, newer oral anticoagulant drug. What? Rivorabaxan, Rivorabaxan, Apixaban. So whenever XA comes, this XA, so they are acting on the factor 10A. This is how the name comes. So wherever you see the drug name which includes XA, X means 10, factor 10 is X in Roman. This is English 10, this is Roman 10, right? So whenever XA comes, means it inhibits the factor 10A, right? And these are the drugs. So whenever any drug, so have you heard some, I don't know whether you work in emergency or hematology unit, have you heard very common drug Xarelto? Xarelto. Have you heard of this drug Xarelto? Right? Apixaban, Dabigatran, Rivorabaxan, Apixaban. So XA is a 10A activity. So see the at different level drug act and inhibit, and that is how it comes the name warfarin, heparin, neuroral anticoagulant drug. That's it. That's it. They act on different level. They try. Say patient has a deep vein thrombosis. Patient has a pulmonary embolism. How you treat? You give heparin, low molecular heparin. Where it acts, it blocks the 8. Clot will not happen. Blood will become a thin. Patient has anticoagulant effect. That's it. Is that clear? Yes or no? Yes or no?
Yes,
Yes,
sir.
sir.
Yes, sir.
That's it. So this is what the clotting is. This is what the clotting is. Now go and read the questions and give me the answer. What is the answer? I tried to give you the complete concept of CBC, means platelet, PT, APTT, fibrinogen, and von Willebrand things. So I think you should not go wrong now. So do you think factor 5 deficiency? What happens? Say for example, factor 5 deficiency. Look at my chart. Where is factor 5? Factor 5 is the common, right? So this is factor 5. So when there is a factor 5 at problem, there is a PT also increase, PTT also. It's a common pathway, na? Both will increase. Is that clear? That is why it's a common pathway. Yes or no?
Yes,
Yes,
sir.
sir.
Right. So here you see it is unaffected. PT is unaffected. So this is gone. Warfarin therapy, what happens? Warfarin, when you give it, increases the PT. Again, increase PT. PT is unaffected. So this is also gone. Right. First of, let me see. Glanzmann's thrombosthenia and Bernard-Shawley syndrome both are platelet functions disorder. Platelet functions disorder, right? And von Willebrand. So, but these two things does not carry factor 8. Factor 8 is not carried by these two. So PTT is not affected. PTT is normal. Isn't it? Yes or no?
Yes, sir.
And von Willebrand disease is the answer. It is one of the most commonest inherited disorder across the globe, von Willebrand disease. What happens? Von Willebrand factors, right? It's a platelet functions disorder. It will not allow, and it also carries factor 8 to make a clot. So what happens when von Willebrand is not there? Platelets not get aggregated, and also the factor 8 is not there. So because of that, you get a PTT high. Factor 8 is where? Intrinsic or extrinsic? Factor 8 is where? Intrinsic or extrinsic?
Intrinsic.
Intrinsic what increase?
APTT.
APTT. Is that clear? So APTT will increase in von Willebrand because factor 8 is not carried well. And that is why the scenario APTT is prolonged or PTT is prolonged and bleeding time is high. Why bleeding time? Platelet functions disorder. It not allow the blood to clot. So von Willebrand will not just affect the platelet, but it also affect the factor 8. So PTT is high, and sometime, right? You get a thrombocytopenia as well, but it is not mandatory that every patient of von Willebrand you should get a things. It's little tricky subject, but just I'm trying to give you the example. And this von Willebrand factor can also be checked and monitored in the serum. We regularly ask for serum von Willebrand factor. We ask for, right? When the PT, APTT and everything is normal, then we'll check, not in the first lot. So hopefully I tried my level best to make this chart complicated, little simpler, right? So that probably helps you in your exam to solve the other questions as well. So this is von Willebrand disease. You go and read it. I had a lot of literature of von Willebrand disease. I will share the PowerPoint with you. So don't worry. Last couple of questions, 2 or 3, just bear with me. Check your score. I want your score. Out of 6, how many right, how many wrong? If it is less than 3 correct, not good score. Check your score. I'll not ask you, but you need to work hard on your subject, right? Out of 6, 3 wrong, not good score. 7. 36 years old man present to a clinic with a complaint of genital sores. The patient is sexually active, heterosexual, involved with the 3 partners and practice unprotected intercourse. 4 days ago, he noticed to have painless sore on his penis. He is afebrile with a heart rate of 80. Blood pressure is normal, 120/77. Physical examination reveals a solitary ulcerated lesions located on the lateral aspect of his penis. The lesion is non-tender and associated with a bilateral inguinal lymphadenopathy. Physical examination is otherwise normal. If left untreated, this man is increased risk of which of the following? Very interesting. Ascending aortic aneurysm, coronary artery aneurysm, endocarditis, mitral valve stenosis, rupture of ventricular free valve. My triad comes here again in the picture.
This is syphilis.
Diagnosis,
This is secondary or secondary
investigation,
syphilis.
and treatment. So first
This
of all, what's the diagnosis?
syphilis.
Syphilis, primary, secondary, or tertiary?
Primary, because it's a painless and
Wonderful. So I already
indubitable
given you the lecture
sample.
little bit, right? Primary, secondary. So this is a classical primary. Why? multisexual partners, so sexually transmitted disease, right? Genital, penile, classical ulcer is there, right? Solitary ulcerated lesion on the penis. So this is a primary syphilis, right?
If
It
it is
could,
left untreated, it can go for the tertiary, like serious. What it affected is aortic aneurysm.
yeah. So what bad could be? So second, if goes untreated, as we discussed, right? Tertiary is neurosyphilis, cardiosyphilis, or cardiac syphilis, isn't it? So aneurysm is the things, right? Primary syphilis as per the symptoms. I already told you the chart, right? Primary, secondary, tertiary frame, right?
Sir,
Sorry,
sir,
but it,
excuse me, one doubt, sir.
yes, please.
In this question, towards the last it is mentioned bilateral inguinal lymphadenopathy. So it is mostly in primary you have a lymph node involvement.
Usually not, usually not. They usually go in secondary, but you can develop lymphadenopathy usually in a secondary. But the
Okay.
logic what they are saying, if untreated, so whether it is primary or secondary, say for discussion, if you don't treat this patient, what bad can go with this patient?
Oh,
Man is at
okay.
risk of what following after 1 year, 2 year, if you don't treat the syphilis. Either you
Tertiary
have cardiac
syphilis
syphilis or you have a
neurology.
neurosyphilis, right? So neuro is nothing here, all cardiac, aneurysm, endocarditis, so everything is with heart. So something goes wrong in heart, so they just trying to understand which complication would be the bad for this patient, or what is commonly seen or worst in this patient. Is that clear?
Yes, sir.
Right? This is a result of aneurysm, aortic aneurysm, right? This results, if you don't treat, this can result in aneurysm of aorta. So aortic aneurysm and aortic valve incompetence, right? Which is not there here, mitral valve, not the aortic valve. So that is the wrong answer, right? So aortic ascending aortic aneurysm is the answer. Coronary artery aneurysm does not happen. It does not involve the coronaries, right? Endocarditis is usually in a prosthetic valve, IV drug abuser, right? And past history of endocarditis, which is not there. It caused the aortic incompetence, not the mitral, and it has nothing to do with the valve rupture. That's it. So this is what the thing is. These questions you need to know. Syphilis cause. What is the cause of syphilis? Exam question. How you differentiate primary, secondary, tertiary? I told you. Exam question. Diagnosis of all the stage, primary, secondary, tertiary, that is RPR versus FTAABS, that is the diagnosis. Treatment of all stage, primary, secondary, tertiary, how you treat, and what is JHR reaction. These all are the high yield questions. So again, the answer of all these things: syphilis caused by Treponema pallidum, primary, secondary, tertiary, I already told you. Diagnosis by RPR and VDRL as a first line, and once you confirm by the FTABS, treatment of choice is penicillin for all the stages. And JHR. So what is JHR? Have you heard of JHR reaction? Yes or no? Anybody? We are 50
Yes, sir.
people, right, in the class. So JHR is what? I just mentioned JHR. What is JHR? Harris reactions seen in secondary syphilis, usually primary or secondary, but more in syphilis, secondary. Exam question, that is I highlighted. What is the treatment? Treatment related side effect. It is not a allergic reaction. It is absolutely treatment related. So if you have a secondary syphilis or primary syphilis, if you treat with the penicillin, then patient develop the rash, patient develop fever, patient develop blah blah. That is treatment related, not the allergic reaction to the syphilis, right? So it's a treatment related side effect. We usually start after starting the treatment 6 to 12 hours after treatment, and usually subside in a 24 hours, usually subside in 24 hours, and it is misdiagnosed as allergic reaction. So these reactions happen in syphilis. You need to know. And what is the treatment of this? We need to know all three things in one MCQ.
NSAID.
MCQ: investigation, diagnosis, treatment. Treatment is a benzathine penicillin whenever possible, except that ocular. This ocular syphilis you need, right? Otic, ocular, and then otic, I miss O, and neurosyphilis. Here the treatment is different. Neurosyphilis treated with IV penicillin G, not the benzathine penicillin. This is a rare. So this is what they ask you: what is the treatment of choice for neurosyphilis? Don't answer benzathine penicillin. Answer penicillin G, IV. That's all. This is the syphilis in overall. Is that clear? Yes or no? So these all are the questions related with the syphilis, from the investigation, from the diagnosis, from the complication, various syphilis, neurosyphilis, different treatment, simple syphilis, different treatment. Last couple of 26 years old man present with the increased thirst, urinary frequency, nocturia over the past several months. Physical examination is unremarkable. 24 our urine osmolarity is less than 300 milliosmolar per liter. A fluid deprivation test does not result in an increased urine osmolarity. Administration of 0.03 desmopressin result in urine osmolarity increase from 300 to 450 after 2 hours. Which of the following is the most likely diagnosis? We always try to avoid this question: diabetes insipidus, central, nephrogenic, and this is the question in exam. What to do? Central diabetes insipidus, diabetes mellitus, nephrogenic diabetes insipidus, psychogenic polydipsia, SIADH. I need the explanation, not just ABCD. Sorry for making a bit more tricky questions today. Yeah, I expect at least 10 answer from 50 people. Just 3-4 answer out of 50. Yes, Catherine. What do you think, Catherine?
Sir, here the yes, sir. Here the test is a fluid deprivation test, water deprivation test. So when it is central, there will be a sharp decrease in the urine volume.
Okay, so what is this? This is diabetes insipidus or mellitus, first of all, or any other?
Insipidus, sir.
Okay. So
Diabetes.
what is the difference between diabetes mellitus and diabetes insipidus? If you know the basic, you can answer anything. Believe me. So I always stress on basics. So what do you think? Where is the problem in diabetes mellitus and what is problem in diabetes insipidus?
Sir, basic is the hormonally in diabetes
So
mellitus,
both.
it is insulin, and
Okay,
diabetes
excellent.
insipidus, ADH is there,
Excellent.
antidiuretic hormone.
Wonderful. Very wonderful. You hit the dot. Right. So primarily diabetes mellitus is a endocrine problem. It's a insulin problem. Insulin either not released or resistance develop the diabetes, isn't it?
Yes, sir.
ADH. So something wrong. ADH is decreased or ADH is not working well. It's a diabetes insipidus. Forget about central, peripheral, or just come to the basic. Fair enough. What is the functions of ADH in our body? If I myself doesn't have ADH in my body, what happens? Or how I present? What's my
Diuresis.
symptoms?
The urine volume, dehydration.
Polyuria.
Okay, so polyuria, right? So even if I drink water, I polyuria. Even if I don't drink, there is a polyuria, isn't it? Because the functions of ADH, anti-diuretic hormone. So prevent the diuresis, anti-diuretic hormone, isn't it? ADH means anti-diuretic hormone. Diuresis is urine. Anti means try to preserve the sodium and water. What do you think? Yes or no? Primary
Yes,
functions
sir.
of the ADH is to preserve the water,
Water
right?
and sodium.
And
Electrolyte.
sodium that wants to preserve. This ADH basically preserves the water. So what happens when ADH is absent? It will not preserve water. It will not preserve sodium. Is that clear? Yes or no?
Yes, yes.
When
Yes,
it
sir.
does not preserve the water, means it's going out of the body. Polyuria. When you have lots
Yes,
of
sir.
fluid going outside, you have polydipsia,
Mm.
isn't it? When you pass more
Yes, sir.
urine, you are thirsty, so you have polydipsia, right? So this is the things.
Yes.
Excellent slide. I got it from you from internet, not my slide, but I love this slide. This is a diabetes mellitus, and this is they mention the word. Love this word. I listen first time in my life. Pituitary insipidus. Excellent word, because problem is in the pituitary. Got it? But it's misnomer. Diabetes mellitus, diabetes insipidus. So now onwards, it's not diabetes insipidus. It's a pituitary insipidus. Got it? So it's a better word by me.
Mm.
Diabetes mellitus, you see, pancreatic problem, insulin release from pancreas, pituitary hypothalamo-pituitary axis, so it's a hypothalamic or pituitary problem. Due to deficiency of insulin, right? Here due to deficiency of ADH, here rise in the blood glucose, there is no rise in the blood glucose, basic but important. So whenever you have any patients in emergency room, check the sugar. If sugar is normal, then it is not a diabetes mellitus. It could be insipidus. Why? Sugar is not rise. Glucose, right? Urine is of normal concentration, and here the urine is very diluted, where in insipidus, right? Urine output is excess in mellitus, but here enormous, not excess. Beyond excess is enormous. Got it? Here the increased thirst, here excessive thirst, because lots of urine. Even patient is passing urine at 1 hour. Even if he is totally not taking any fluid, he is passing urine after 1 hour, passing urine after 1 hour. So it is called as a large and frequent. Large and frequent, two different words. Large means 1 liter, 500 ml. It's large, and frequent, every half an hour, frequency. So both are different words. Large and frequent urination in diabetes insipidus, right? Like in mellitus, frequent but not large. You understand what I'm trying to explain, right? They are going many times. Both people are going many times. But in pituitary insipidus or diabetes insipidus, large volume is passed, right? And there is a excessive eating in diabetes mellitus. There is no excessive eating in insipidus. Ketones in the blood and urine. There is no ketone in blood and urine in insipidus, right? Cholesterol usually rise because it affects the cholesterol metabolism. Excessive sugar where it does not affect. So diabetes insipidus, where the cholesterol is normal, treat with the insulin and lifestyle changes. Treat with the DDAVP, desmopressin, and incidence is too high of mellitus, almost 1000 in 1 lakh people. Here 3 in 1 lakh people. Hopefully you like this slide, yes or no? Yes or no?
Yes.
Excellent slide by my. Right. So this is first of all, so you need to make a complete clear-cut concept in your mind. What is diabetes mellitus? What is diabetes insipidus? Until and unless you clarify this, it's difficult. Central versus peripheral or nephrogenic. Comes to the central or brain or pituitary or adena, right? Hypothalamus or this pituitary gland. If something goes wrong in the center or in the brain, is in the central. CNS, central nervous system, and central nervous system includes brain and spinal cord. Same way, central diabetes insipidus means something wrong in the central nervous system, that is brain or spinal cord. So here the brain, hypothalamus or pituitary. If not making, it is a central. If it is making well, but it is not acting at the level of kidney, then it is a nephrogenic. That's it. This is the biggest simple difference. Central diabetes insipidus reduce ADH, antidiuretic release here, right? Like diabetes, reduce insulin, diabetes mellitus, reduce ADH, diabetes insipidus central. What happens in nephrogenic? ADH resistance. So both are, it's like a, remember the diabetes same. Type 1 diabetes, insulin deficiency. Type 2 diabetes, insulin resistance. Central, insulin ADH deficiency, ADH resistance. That's it. This is the simplest definition. So here in nephrogenic, ADH is absolutely fine, releasing fine from brain and hypothalamus, right? But at the level of the kidney, where the renal reabsorption of water and sodium happens, it does not happen. That is nephrogenic diabetes insipidus. So central is idiopathic. It could be idiopathic. It could be trauma, head injury. Always you see, right, head injury, because it affects the hypothalamus and pituitary. You develop diabetes insipidus. Intracranial surgery may injure again the same organs. And ischemic encephalopathy, stroke, after stroke, some patient develop diabetes insipidus, right, because of not releasing the ADH, because of hypofunctioning of pituitary or hypothalamus, right? Here drug commonest they ask in the exam is lithium. Lithium is the classical common drug. Lithium is a drug used for manic depressive disorder. Psychiatric lecture we'll discuss sometime. Lithium is a drug primarily used for manic and depression both, and known as a bipolar. Bipolar means two pole, mania and depression, bipolar. Lithium is a drug of choice. Exam question. So drug lithium, very important. Electrolyte abnormality, etiology. Kidney disease, obviously primary kidney disease. You have ADH, enough ADH, you have it, but unfortunately kidney is bad, so it cannot properly functions, right? And this is extremely rare hereditary V2. I have not seen this patient, though I'm not nephrologist, but I have not come across much. Clinical features by and large the same. Polyuria, poly means too much, nocturia means night. Here polyuria, polydipsia and nocturia. Here high sodium, this is normal sodium. See, high sodium, high serum sodium. Why? Because, sorry, I got a call, right? So diabetes insipidus, normal sodium and increased urine osmolality, here no change. That's it. So this is how you have to understand and learn. So your again homework is to go and read once again the diabetes insipidus and mellitus both. Lots of questions come from this. This is a central diabetes insipidus, is a deficiency of production of ADH in the posterior pituitary. Can anyone tell me how much hormones released from the posterior pituitary gland?
2, sir. Oxytocin and ADH.
Excellent. Very brilliant. Oxytocin and vasopressin. And this vasopressin is ADH, isn't it? Yes or no? Doctor?
Yes, sir.
Or am I right or wrong? Go and check it.
Yes, sir.
Vasopressin and ADH is same or not? Go and check it, homework. Right?
It's the
So
same.
yeah, it's the same.
Same.
So oxytocin is mainly the female, right? So what's the main functions of oxytocin? It lactation, number one, and second is a uterine contraction at the time of delivery. So these two key major functions for oxytocin, vasopressin or ADH, major functions, sodium and water retention. If not there, then you get a problem. That's it. So go and read it once again. I try my level best to simplify it. Last couple of questions, bear with me. 36, 8 questions. Out of 8 questions, if you are 4 correct or less than 4 correct, not good score. Sorry to remind you, but you need to work more on it. 36 years old man comes to the primary care physician with a rapidly expanding rash. Easy questions, don't get this disappointed. 36 years old comes to the primary care physician with a rapidly expanding rash under the right arm. The rash is round with a central clearing. Upon the questioning, the man admits that he has been feeling somewhat lethargic and achy lately, but they attributed this to a fatigue after a recent hike in this valley in the Virginia. Which of the following is most likely diagnosis? Infection with Staphylococcus aureus, Lyme's disease, meningitis, myocarditis, Rocky Mountain spotted fever. Very nice name. I love this name, Rocky Mountain. Yeah, it's not a difficult questions. I think it's a easy, very easy questions. Even those who cannot answer this, I will show this picture. Then you must answer this. Only one picture, self-explanatory. Spot diagnosis. What's the diagnosis? Lyme's disease. It's called as a target lesion. Target lesion. So if I can draw the picture, target lesion. So what is target lesion? So this is a lesion, and on the center there is a lesion. Target. You know, when you play the game, there is a circle, 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 and you blow the arrow. Right? Target. So this is like exactly looks like this. Target lesion. Classical of Lyme's disease. So 3 questions in Lyme. How you diagnose the Lyme's disease? Classical rash, and there is a until proved otherwise there is a hiking and tracking history. Hiking and tracking history is there. So both things are there. Rash is there, hiking history is there. We'll go back. They are hiking in the Virginia. They mention already in question, right? Investigation, it's a clinical diagnosis. You see the target around this, right? This is the things. And the treatment is a doxycycline, right? Again, like this syphilis, it's a primary, secondary, tertiary, like that. This is a Lyme's disease. So Lyme's disease in advanced stage, untreated, they may cause arthritis, and they cause the cardiological problem, and they cause the facial palsy, neurological as well, facial palsy. So all facial palsy patients should be investigated for Lyme's disease. Go and read it bit in detail, but this is the bottom line, right? And doxycycline for the skin and these things. For the advanced disease of these things, you can use ceftriaxone is a drug of choice. Ceftriaxone is a drug of choice. So go and read the Lyme's disease. So this is a Lyme's disease, classical presentation of the Lyme's disease, right? So now go back. What is the things? Primary care physician extending right arm. So exposed part usually seen the exposed part, leg or arms. So exposed part is there, right? Central clearing means target central clearing. This is center and center clearing, right? And there is a hiking history of hiking or mountaineering or valley in a Virginia. What's the diagnosis? Lyme's disease, Staphylococcus aureus. Usually it's a red, tender, fever, blah blah, meningitis, lots of neurological symptoms, knuckle rigidity, chronic signs positive, myocarditis. Patient has some history of infection, ejection fraction less, fever, right? Any injury, history of acute MI is there? It is different. That's it. So this is how you have to exclude. So that's all. This is Lyme's disease. So you must know what's the Lyme's disease. Last but not the least, questions for the end of the sessions today. We have a little feedback and then we'll pack up and enjoy our Sunday. That's it. So this is Lyme's disease. And last, some vaccines cannot be administered to a pregnant woman. Recent question in exam. Some vaccines cannot be administered to the pregnant woman. So you need to know first of all which can be administered, which cannot be administered, or immunocompromised patient, because that's the homework. So some vaccine cannot be administered to a pregnant woman or immunocompromised patient because they contains the live virus. And live virus, there may be a directly you are introducing the disease because they are immunocompromised, either immunocompromised and pregnant. Pregnancy itself is a immunocompromised state. Several vaccines used today are safe for this population because they contain inactivated virus. Activated or live virus cannot be used, so you can use inactivated virus. So it protects against the disease to a pregnant, same way it does not cause the disease manifestation, right? So which of the following vaccine contains inactivated virus? Intramuscular influenza vaccine, mumps, measles, rubella vaccine, oral polio virus vaccine, rotavirus vaccine, varicella vaccine. Bear with me 5 minutes. Last question. Yes, anyone?
Influenza.
Intramuscular influenza is an inactivated vaccine or activated? Sarin.
Intramuscular inactivated influenza vaccine.
Okay. So what is B, C, and D and E? All are activated?
Live vaccine.
Or live vaccines.
So mumps live vaccine, oral polio live vaccine, rotavirus live vaccine, varicella live vaccine. So these all are the excluded. So what remaining? Intramuscular influenza vaccine is the answer because it's inactivated virus. That's all for today, and we'll catch up the next. So before I finish and end my lecture, I want few candidates who are first time attending my class. Just give a general feedback. What is excellent and what is new for you? What fascinates you today in the lecture, which you never heard in your medical school? Only old one.
I'm attending for the first time.
Sorry, who is this?
Naina.
Yes, Dr.
Dr.
Naina.
Naina.
Sorry, I'm just trying to understand how was your experience.
So that intrinsic extrinsic pathway thing, that's really new for me. I've tried to learn it in many ways, but this one seems to be the easiest. What you taught today.
Wonderful. Probably my hematology experience helps. Great, wonderful. So you enjoyed overall.
Thank you, sir. Thank you, sir.
Wonderful.
Yes, sir.
Yes, and even Catherine, I think you are also first time, I guess. What's your experience?
Sir, I really like the class today. Though we are covering only 10 questions, like the way you said, it's more like we are covering 30 questions and it's very interactive. So that's good. I've attended other classes like other schools and all. It wasn't very interactive. So you keep it alive. So you know, you motivate us also. And I Like the previous doctor said, I really liked your intrinsic extrinsic pathway class. That was very new and it's very easy. I didn't know it was this easy.
No problem.
So that was good, sir.
Great, wonderful. Anyway, so bottom line, you enjoyed. I'm happy. Anyone else, last but not the least, last anyone who attended first time? Yes, Preeti. Sorry, I did not ask you a lot of questions today because last time I catch you. So I thought I'll make you free this class. Yes, Preeti, what's the new learning for you today?
Sir, the class is very excellent and new learning is everything is new learning actually for small mistakes I have been making. It is very excellent. The coagulation disorders really, sir, I've been forgetting every time. It is very useful, sir. Disorders, I mean to say,
Anyway,
especially, sir.
anyway,
Thank you so much, sir.
no problem. Any hematology help? I'm not, I mean, claiming I'm expert of all, but absolutely hematonc, I'm the expert because I'm practicing for last more than 20 years now in hemato-oncology and bone marrow transplant as a super specialist in corporate. So hemato-onco, I mean, any topic you can approach me, my consultant, what we discussed earlier. But hematon, if you have any questions, even personally, you can discuss. I try my level best to make it clarified. Just the main concept, if you understand the concept. Otherwise, we mug up every time von Willebrand disease. We don't know what is this von Willebrand disease. But I don't think so. Now you forget. At least you know the basic, right? What is factor, how it works, how it gathers, what are the three different type, how to treat, where from endothelial it release. You understand? So probably makes your life bit easy. Anyone last? New or old? Anyone last? New or old?
Yeah, this one way Librance factor I was trying to mug up, but today it was an eye opener.
Thank you very
May
much.
I speak, Dr. Munjal?
Madam, you don't need. You are my senior. You can speak anything, ma'am. I respect
So
you. It's my
I
pleasure that you
just,
are in the class. Believe me.
no, I was just thinking that I'll just mug up and, appear for the exam. But today I realized that each question has different modes of answers. And the way you have explained it, I'm truly impressed because I've been practicing a totally different line as for 30 years. For me, going back to medicine, it seems so interesting the way you have explained. I've
Thank you
never
very much.
experienced anything like this many decades ago in my medical college. And I'm truly impressed. I'm happy I joined this.
No, no,
Thank
my
you so
pleasure,
much.
madam.
And all the best, all you young
Thank
students
you.
there.
Thank you very much for your blessings, madam.
Bye-bye. Bye-bye.
Thank you very
Bye-bye.
much. Thanks, everyone. See you
Bye.
next week. You can post in our group as well. Little feedback that motivates us. That's it. Nothing more than this. We'll catch you soon. Thank you very much and enjoy your Sunday.
Thank you, sir.
Thank you. Take care.
Thank you, sir.
Bye bye. Take care.